mostly based on the evidence-based toolkit that's out there, and it would help us kind of present recommendations for each and every patient that walks into our door. Plus, it's kind of based on the model in the Middle East where I'm practicing. And I'll talk more about that in a second. Allow me to introduce myself very quick. And I work at a European University College, just as Mr. Chairman mentioned, and I practice privately in Abu Dhabi. So I work in 2 different cities. And between Abu Dhabi and Dubai, I'm originally from Egypt. I would like to shed light on the caries experience in the UAE, some of the caries prevention tools that we can use. It's not working. And perhaps tailor-make some recommendations, plus talk a little bit about the reality check of how the situation is and what we do. And of course, at the end, introduce some paradigm shifts that would be really helpful in the Middle East where everyone's practicing, because there are things that are practiced still differently. And because we are pressed for time, I will be like picking flowers from a garden. So we open our clinics first thing in the morning, and this wonderful 3-year-old walks right in, and we ask a little bit, so mommy, what brought you here today? She says he stopped eating and he has pain at night and it's severe. And you ask a little bit more about the diet. He says, he's still on the bottle. And okay, tell me more. She says, well, night feeding. He loves it at night, maybe 5 to 6 times per day. And then you ask a little bit more about his snacking habit, whatever. She says, oh, he loves his Galaxy chocolate. 7 times per day, more or less, every day. And that's how it goes. And when you ask about the brushing, she looks at him, she looks at me like, why are you asking me this? And she says, well, he does his brushing. What a stupid question. And then, of course, this Danny, he's as intellectually intelligent, emotionally intelligent as 3-year-olds. He understands, well, this is a doctor. He's probably going to stick one of those needles into me. So why don't I play mommy up and scream bloody murder for the entire time at the office? And, of course, after we get a look in Danny's teeth, this is what we see. It is chaos, mayhem, and this kid is not going to sit on our chair anytime soon. So the million-dollar question is, and this is every patient we see there, what do we do? And the first paradigm shift of the day is the drill and fill approach no longer works. We don't shoot with the drill and ask questions later. We always start with prevention first. And again, if all the GPs I know that were practiced in the UAE started with this, we would be at a much better position. Now, let me show you what's the population I'm talking about. And I wish I had more studies to show, but because I'm pressed in time, I am generalizing from the UAE. The risk factors are the same in the Gulf state and in the Middle East. So we start with 5-year-olds, and 5-year-olds, they just had their teeth in 2 years and a half, and if you look, the decay experience is 83%, and that's huge. And if we look at their DMFT, it's 5.1. A quarter of their teeth are already decayed. If we take a look at 12-year-olds, and their teeth are just freshened, 54% of them have decay, and their DMFT is 1.6. For those 15-year-olds, 65%, and the DMFT keeps rising, which is 2.5. Now, the thing is, these results are based on a national survey, and the national survey, by the time it was published, that was in 2010, and of course, by the time it got written and whatever, all I'm trying to say here is this is an old study. So the caries prevalence now is a lot more, but we do not have it reported as yet. And now the funny thing about icebergs, before you hit them, you can only see 10% of them, and this is only what we see. So this study was diagnosing caries at the D3 level, which means it's an overt clinical lesion that you crawl into and you find. But what about these, what do you call them, sneaky white spot lesions or decalcifications? They are not reported in any of the studies. So all I'm trying to say is that the caries experience reported is a lot less than what is reality. And now you can appreciate that in such a population like this, there is a definite high risk. And it's just not caries, there's dentally uneducated individuals. Majority still seek pain only when there is pain, seek dental treatment only when there is pain. There is no recalls, no regular recalls. The diet is highly cardiogenic. The whole culture is about cardiogenic food. And I can keep talking on and on and on about risk factors that are present that we're up against. Now, the thing is, it's always so good to appreciate what we're up against and the etiology of caries, and then understanding what link to break in each and every individual that we see. Because again, caries is a biofilm disease, and it's dynamic, but why are we still stuck in the paradigm that we need to eliminate the bacterial film? Why don't we just try to modify it? And how do we do that? Now, again, we have a lot of factors or a lot of tools in our toolbox that we can use for each and every patient that walks into our clinic that we can help modify the caries experience with. Our first tool would be caries risk assessment, and again, another of those paradigm shifts that individualized prevention is the key. We no longer have a one-size-fits-all jacket. Oh, you're a patient, 3-year-old, take it. 4-year-old, whatever. So the thing is, we can never treat our children alike. We cannot treat special needs just like any other deprived individuals, medically compromised. We have to know who we're targeting and how. And the thing is, caries risk assessments, there are tools for us to be able to predict if future caries is going to happen or existing lesions are going to progress. And they're important, again, because we're stuck in time. I'm not mentioning them, but they are important. And the recommendations that I'd be given are always based from guidelines that we have available to us, and they always link the grade of recommendation based on the level of evidence that it is taken from. And the best sources, whether they're British guidelines or the AAPD, the American Academy of Pediatric Dentistry, if you're ever stuck and you need a recommendation, go to one of those websites, and they're free and they're available. Now, I'll tell you about the first toothbrushing advice I need to give each and every patient I see. As first, who brushes? Because they always say, well, he brushes or I brush, but then they brush and the flask scores are 4, and you're like, seriously, do you really brush? And each and every patient has to receive the instruction that you have to brush your own kid's teeth. And little tip, spit out the excess paste, but do not rinse with post-brushing. And this little tip, being told from a clinician, goes a long way because it helps. Plus, it decreases the fluorosis risk if the parent is more involved. And the thing is, the parents in this population, they're not interested, they're not involved. Only when you tell them, they kind of understand, oh, I need to do this. And of course, bedtime, the importance of pre-bedtime brushing does not happen because they say, well, yeah, I brush. And you say, when? Say, morning. But what about bedtime? And only when we mention it, they realize it. Now, about flossing, do not get me started. If they don't brush, will they floss? So I always give this advice when it's a motivated mother, which is like 5% of patients I see. Again, the techniques for brushing, well, we do not need to go through with all these different techniques on how to brush, what to do, whatever. The evidence tells us that just modify the patient's existing technique and just help them brush systematically. And that's all we need to do. Now, for disclosing agents, I use them sometimes, but the funny thing is, if it's a girl, she'll look at it and she'll be horrified. Oh my God, it looked bad. And she's gonna go brush. But if it's a boy, he wants to look horrifying. He wants to look scary, and then he won't brush. So I don't know what's a win-win situation in this. And again, most mothers, because they don't care, plus, the nanny's the one that takes care of the kid anyway in 80% of the population. So I need to show them how to brush. I need to show the nanny how to brush. And even those little ones that are kicking and screaming, we need to show them how to handle this. They don't know. And this is their reality. And unfortunately, it's our reality too. So now let me tell you about diet. It is my job. Again, I told you about my population, uneducated about the diet effects. And again, our reality is, they love breastfeeding. Breastfeeding takes place until 2 years, and plus, they love bottle feeding 5 to 6 times per day. Even at older ages, I've seen a patient last week whose breast bottle fed at 6 years, and bottle feeding still happens. Now, and they get creative about the baby bottle sugar additives. You ask them, okay, so what do you place in the bottle? And they say, milk. Oh, fine, that's great. What else? Oh, sugar. Honey? Yeah, okay. Jam? Oh, God. Biscuits? Yes. Oh, my God, what's happening? And the thing is, they get creative. If they can put it in a blender, they're going to put it in the bottle. They're going to feed it to the baby. And it's up to us to recognize what are they really doing, because they do not tell you the first time you ask. They say milk, and they just smile. But you know from the child's mouth what's happening in there. And again, the funny thing is, because the whole culture is based about eating, the mom cooks something yummy, places it in, and says, well, just go eat. And then every 5 minutes, the kid comes and goes and eats something. And this is a horrible way to feed a child. So now I told you about the reality, and the thing is, there are a lot of hidden sugar traps in the market. Plus, everyone, even the 2-year-olds and the 1-year-olds in their bottle, receive Pepsi. So we are up against a lot. So what do? The thing is, we give them a diet diary, we look for what they're doing, the real thing they're doing, and then we formulate their advice accordingly. And again, another one of those paradigm shifts is that we no longer classify food as bad food, good food. We try to educate them about healthy diet, bad diet. Because if you tell a 2-year-old or a 3-year-old, oh, chocolate's bad for you, do not eat it, child is like, no. You go get a life and have some of it sometime and not be so uptight. It is yummy, and it is yummy. But if I can educate him, eat a chocolate, eat an apple, go brush your teeth, that is a lot more sustainable. And of course, in this message, I have to make him understand that twice a day they have to brush, and then they can eat anything in between sensibly. And this goes a long way too. Plus, recommend some protective feeding, like giving kids nuts after meals or cheese after meals for their positive balancing effect, or giving kids xylitol, or perhaps baking with xylitol products, because the community loves to bake a lot. How about probiotics? Really, probiotics do not have a lot of evidence behind them, so I'm not going to go through them, but they would be interesting if this population has a lot of caries and there's something we can give for us to balance that. Now, the diet advice at the end is, do not give sugar, do not put the bottle, don't. And if I tell you, do not think of that pink elephant running around everywhere, what are you thinking of? You're thinking of exactly that nice pink elephant running everywhere. And that's the same thing for the mother. If you tell her, do not, she's thinking, oh my God, I want my baby to have some sugar, please. And seriously, so what do we do? Again, by the American Academy of Pediatric Dentistry, there's motivational interviewing, and it's really just a counseling technique. It relies on a really open channel between the clinician and the parent, where you are helping them. You're an alliance. You're not the enemy. You're not telling them what they're doing is wrong or making them feel guilty about it, and you start with it one thing at a time. So let's say bottle feeding, you take that, you decrease it, you give them proper advice that they can do. It's personalized. You tell them, okay, well, I understand, but how about decrease that milk content maybe into a quarter for the first week? Try it. How about that? And then it goes a long way too, because they understand that you understand. You're not just handing out some recommendations that you've learned somewhere and you're giving it to them. You actually care. Now, I'll tell you a little bit about the fluoride and really quickly. And again, we all know how to increase our fluoride availability. Now, do we have water fluoridation? Unfortunately not. And we drink from bottled water, and there's just 2 or 3 companies. So I'll presume this population gets no fluoridated water. Now, how about the supplements? Don't get me started on the supplements. We don't get them if we want to. And anyway, whoever needs the supplements does not take them if you prescribe them, and whoever does not need them actually ends up taking a lot of them, hence fluorosis. So again, this is not a tool I can use in my population. So the real actual tool I can use is the toothpaste. So I have to prescribe toothpaste to each and every patient, or they would end using one of those organic toothpaste, because I've had a lot of patients and the caries is rampant. And I'd be like, so what are you really doing? And their diet comes up not that bad. So I would ask about the toothpaste, and they would say, well, here it is, and it has 0 fluoride, because the market is unregulated. So, and the evidence tells me that any less than 1,000 part per million fluoride is ineffective at controlling caries. Then it is up to me, up to all the GPs, up to all the pediatric dentists to prescribe that appropriate dosage. And there is this fantastic document that organizes prescriptions according to age and tells you if it's a smear or a pea. And if the caries risk is high, then you go up and upgrade the paste. And only if you prescribe it to the patient, he will follow your instructions. And again, the trick is, according to one of the important studies that happened back in 1999, to use a high concentrated paste, but very small quantities for children aged less than 6 years. So you upgrade the prescription but you decrease the quantity for it to last a long way. Now, fluoride varnish, again, wasn't available in the market until like 2 or 3 years back, and a lot of people still don't know that it's still there, that it's newly introduced in the market. According to a very good Cochrane in 2013, the varnish application decreases caries by 43% in permanent teeth and 37% in primary teeth, and that's huge. And we want our dentists to keep using that for every child they see. And the thing about varnishes, it arrests existing lesions and it maintains the fluoride for longer in contact with these lesions to be. And we apply it twice or thrice per year, and it would go a long way. And if we give proper post-varnish recommendations, it will definitely help out. Now, I have to hurry with this and just get the proper varnish recommendation. And for people with allergy, there are alternative varnishes. Unfortunately, people still use acidulated phosphate fluoride gels. They do bring about 26% caries reduction, but if we mentioned 43% caries reduction, this is not to be used anymore. Plus, the risk of it being ingested, because the tray can, a lot of quantity can be placed, and improper technique can lead to a lot of problems. Now, there are alternatives to to fluorides. And one smart guy thought, well, tooth is made up of calcium and phosphate. What if I have a supersaturated saliva with calcium phosphate? What's going to happen? Tooth movement came into play. He added fluoride to it. Then along came MI paste, and there is a varnish with it too. And the preventive fraction for this was 42.5%, which is huge for those white spot lesions. And I'll hurry right up and I'll talk a little bit more about things like these. And I see them a lot. And then what happens is a lot of dentists don't know what to do with them. Some just drill them out, and they're just white spot lesions. They are waiting to remineralize. Just give them a chance. Give them the appropriate things they need. And I've just talked about MI paste, so we can actually just use MI paste. But for the ugly scars, something else that we can use is Icon. And Icon is just like a fissure sealant, and all it does is it seals these pores and helps the surface be intact again. And we can talk later about how to do it. It's not that difficult. And the recall, putting each and every patient on a very strict protocol is really something, because parents are still under the paradigm that we only go to the dentist when there is pain. And this is Danny after we sat him in, explained pediatric dentistry, did all our bit, and what we're really interested in is to provide comprehensive management of a child as a whole, not treat a tooth. We are treating children, and this is our life, despite the pees, the poos, and the pukes. And I always tell my patients, brush the teeth you want to keep, or this will be your end. Thank you very much. Any questions?
A couple of questions. We have a moment or two.
Is there any communication between the dentist and the pediatricians?
Unfortunately, well, I would like to say yes, but most of the time when I send one of those nice referral letters telling them to do something or the other, it gets lost. I'll tell you, there is an important part that I skipped, that the model is really based, the government, only 20% of the population can get benefit from the government. So only 20% of the population are, well taken care of. But everyone else, the 80%, relies on private practice. And private practitioners do not speak well to each other. They're just in their bubble. So the pediatricians don't have this lift the lip. They only when a child comes and he's in obvious pain, and then they think it's tonsils, and then they go to the pediatrician goes, oh no, this is not mine, go to a pediatrician. And that's the only way where there is some sort of collaboration.
Have there been political actions to get fluoride in Dubai, in the water?
Well, to be honest, yes. And since I work at a university, we have a lot of efforts that are going on for us, but the thing is, they are not going to do it anytime soon. And people do not drink from the tap anyway. So you're talking to bottled water manufacturers. And some of them are actually taking action, and just one more product was introduced. Does everybody have that product? No. And does everybody know about it? No. So that's the thing. A lot of people come and say, what is fluoride? Or some know something about fluoride and they think fluoride is bad. So when I suggest, I'm going to put fluoride varnish, they think, oh my God, what are you going to paint my teeth with? So this is what we're functioning from.